talk primarily about the impact of marijuana with young brains and how we are setting the course for some people with that early onset, and so that to be really effective in prevention, we do need to address the onset of all these other substances and not just focus on opioids over here as if they're separate from prescription marijuana, alcohol, tobacco, and other substances. So,
well, that pretty much sums up my talk. So.
Did you talk about it being recorded too?
Oh yes,
okay.
Thank you. And
yeah.
It is being recorded today. Reggie is from BCTV, and he manages. We have a coretalks.org is our website, and Reggie he videotapes all of our events, and then we put snippets out on that website. And so if you don't want to be filmed today, maybe, is there anyone who would prefer not to be filmed today that we should know? And it's okay if you don't. And that if you do talk about any stories.
No, you got it. You already knew it.
If you have any stories to share, please don't use names or any identifying features, that we really do need to be confidential, and that, we're here to learn this data, that we do have resources if things come up or you need help around treatment or recovery or anything like that. Please know that there are resources in the room that we can guide you to as needed. So anything else?
I think that's
okay,
it. Good job, Rob.
Well, let me just correct one thing. I'm not the state epidemiologist. That's Patsy Kelso. But I am the chair of the State Epidemiological Outcomes Work Group, and I'm also the Substance Abuse Research and Policy Analyst for Alcohol and Drug Abuse Programs in the Department of Health. I have a very long business card. And I want to
favorite epidemiologist.
I want to thank some people for helping us out with this presentation. Kristen Murray, Amy Livingston, and Bob Llewellyn. The last two are from Pacific Institute for Research and Evaluation. They have a contract with us, and they do a lot of great work. Ann Van Donzel is in huge letters because she's my supervisor. And we often and usually give this talk together, but she had other obligations today, so it's just me. I'm sorry. So we're going to talk a lot about data, mostly state of Vermont data, but I wanted to start off by showing you some national data. This is from the National Survey on Drug Use and Health. The latest data we have is 2016 data, and show you what the prevalence is of both any use and also misuse. So you just take a look at this, and there's going to be some more coming up here in a second. Again, this is age 12 and over, which is what the survey uses as an age cutoff, and we're also going to be talking about specific age groups within that category. So this is just give you a general idea of what kind of drugs are out there, what kind of drugs are being used, and what kind of drugs are being misused. So, oh, by the way, stop me if you have any questions. I'm happy to answer any questions at any time. And this is Vermont substance use. Nothing strange here. Alcohol use in the past 30 days is the highest prevalence, and this sometimes gets lost in the shuffle, as Robin was talking about before. And we're in this opioid epidemic mode, and so this needs to be remembered that alcohol is a huge factor both in mortality and morbidity in the state of Vermont and nationally, and it sometimes gets lost. So I also want to point out one thing, which is this is going to happen a couple of times, but in 2015 and 16, the National Survey on Drug Use and Health had changed the question for the past year of non-medical use of pain relievers. So these data from here on out starts a new trend, and they're not comparable to the data before. I mean, it's a very serious thing when they actually change questions and they know that they have to break the trend. So this starts a new trend for 2015, 2016. It'll be going forward.
I have a quick question, John. Do we have access to these slides?
Not yet.
Okay, cool.
But these data are available online at samhsa.gov.
Excellent, thank you.
Yep. And this is the other two substances that are of importance, which is heroin and cocaine. The National Survey on Drug Use and Health started releasing the heroin data because they didn't have the pain relief data in 2014, 2015. So it's not significantly different. And this, I'll have a lot more to say about cocaine in a bit when I talk about age groups. Well, here we go. Age groups. This is of concern. We've always had in Vermont, we've always been way above the national average. Not way above, but we've been above the national average for 18 to 25-year-olds. And this survey, this is the latest survey that came out for the state data. They usually come out at the end of the year, so the 2016, 2017 data will be out in December of this year. But in Vermont, across all age groups, which is 12 plus, 12 to 17, 18 to 25, 26 plus, and 18 plus, Vermonters are in the top 5 of prevalence of use of cocaine compared to the other states in the country, which is interesting because we don't talk about cocaine much. We don't hear about it. And there's not much going on in the treatment area of cocaine either, but it's starting to get, yes?
We were just at a bunch of us went to the RX Misuse and Opiate Summit down in Atlanta, and there's a huge spike in stimulant misuse, including methamphetamines and cocaine coming from Mexico.
Yeah.
So it's they used to say that you'd either have an opioid issue or a methamphetamine issue, and it seems like they're starting to come, and nobody's really keeping a track on this, so I'm really excited that you're talking about this, because I think we're having that issue in our own state as well.
I'll have a little bit to say, more to say about methamphetamine in a few minutes that I think you'll find interesting. Anyway, I've been here for 14 years, and the first time I tracked this, I was surprised to see that Vermont was in the top 3 or 4 of prevalence of cocaine, and it's remained that way throughout the years. And again, it just it hasn't gotten any traction at this point. It's there. We know about it, and it's not in the treatment facilities. It's not one of the major drugs of abuse that's being treated. So I'm not sure what to do about it except just note it. Yeah.
Just I would make a comment from the treatment standpoint that because cocaine doesn't have as dramatic a withdrawal or as dangerous a withdrawal as alcohol or even heroin or other opioids. It's often taken into account, but there's not a specific treatment unless somebody's so terribly craving and restless they're not going to stay in treatment. In
Yeah.
this case, there might be some intervention. But the kind of subtlety of it contributes to the lack of attention that you described.
Yeah. Thank you. Yeah.
My understanding too is that insurance companies no longer pay for detoxes exclusively for cocaine anymore because it isn't physically dangerous, the withdrawal process.
Oh, I see. Okay.
Yeah.
I don't know anything about that.
Exclusively cocaine. I remember that switch like 6-7 years ago.
So that may be part of the problem as well. Yeah.
And the same for opiates too, because it's not life-threatening. They usually won't cover detox.
Well, it's disturbing, isn't it? Yes.
And at the same time, I'm thinking there is no medicated assisted treatment. for
No,
cocaine,
that's right.
Although
It's a very interesting point. Yeah.
Not yet, anyway.
Not yet, right.
They talked about that, one of the presenters in Atlanta.
Thanks, John.
Okay. Oops, I did that right. There we go. So this is past 30-day alcohol use, ages 12 and plus, compared to the United States to Vermont, the United States, and you can see we're significantly higher. We drink more here in Vermont, probably because of the winters. Is it ever going to end, by the way? Just out of curiosity. And this is 30-day alcohol use by the age groups I mentioned, 12 to 17, 18 to 25, and 26 plus, and not surprising either that the 18 to 25s are leading the pack here. I just can't seem to get this. Okay, here we go. This is binge drinking, and compared to Vermont and the United States as a whole, 50 states and the District of Columbia. And again, here we have this little problem where they reformulated the binge drinking question. So these data are no longer, they cannot be connected because this starts a new trend. And this was an easy one because what they used to have is 5+ in one sitting for both males and females, and they finally adjusted it to 4 for females and 5 for males. So in any case, you can't trend these data through 2015, 2016, just so you know. And this is the marijuana use in Vermont and the United States, 12+. As you can see, we're leading the pack here. We're in the top 3 in prevalence of marijuana use in the past 30 days. A little disturbing. And this is 12 to 17-year-olds, and this is kind of good news, I guess, if you want to say it that way. It's gone down in the last survey. We don't know what's going to happen in the 2016-2017 data, which, as I said, will come out in December.
Do these encompass medical as well as recreational use?
This is just asking the question of, did you use marijuana in the last 30 days? So it could be medical, could be non-medical, we don't know.
Do you think that young people are comparing, like when you ask about marijuana, and this is kind of the same issue right now with tobacco, if they're using like a dab or concentrate, if they're not thinking that, and like they're thinking of it as cannabis and not necessarily marijuana. And I'm just wondering if that needs to get kind of flushed out, because like we're thinking about with like the new Jules product with tobacco, like if they might be like, oh, I haven't used tobacco because it's like to them not.
I think that's I think that's a good question, but the question actually encompasses all forms
Okay,
of
it does,
marijuana
okay.
and cannabis. Yeah,
Okay.
but you're right. I mean, it could be confusing to some people, especially at that age group, right?
Yeah, right.
Sorry. Okay.
Thank
And this is binge alcohol use. Again, I don't want to go through this all the time, but the trend has been broken, and we're still ahead of the pack. This is 12 to 17-year-olds, which is disturbing. And this is any alcohol consumption at all in the past 30 days for 12 to 17-year-olds. Okay, it's got to work. Here we go. And this is 12 to 20-year-olds. This is essentially their concept of underage drinking. As you can see, Vermont is way ahead of the United States in terms of underage drinking for a long time. And it's gotten a little better, but it's not. It's still statistically significantly different than the rest of the country.
John, the previous slide was sort of jagged. Is there?
That's
yeah,
big.
2010 it went way up. Do you have a sense of what that might have been from, or why it went down in 2006?
Yeah, I don't know. I don't. Sorry, I just haven't processed that before. So it's a very good question. In fact, this will make me check the data,
Okay.
which I do with. Robin asked me a question a couple weeks ago. It was about the underage drinking, and I sent her some data that was completely wrong. So I have been known to actually make mistakes in these things. Although I try to be as careful as I can. But when Robin asks me a question, I go, I better check that. So I know the underage drink. I don't want to sound like I'm making all kinds of mistakes, but occasionally you do, and we do have these checked by other people. So I'll check on that though. I'll see
And on
what-
our mailing list, we'll let you know.
Yeah. All right, this is alcohol use, and this is underage binge drinking. And again, it kind of is a problem in the United States, in Vermont, compared to the rest of the country. Okay, here's our problem, one of our problems, and that is 18 to 25-year-olds have an increasing rate of past 30-day marijuana use. Again, if there's any good news in this at all, it's the reduction in 12 to 17-year-olds. But again, these data are 2 years old, so we don't know what's happening currently, which is unfortunate, but that's how they collect data and have to clean it and analyze it and put it together, so it takes a while. Oops, that's what I'm doing. Wrong thing here. And this is past year marijuana use by the age groups, and again, we're statistically higher in all categories, 12 to 17, 18 to 25, and 26 plus compared to the rest of the country. And this is also a problem. This is perception of risk for substance use. The gold is perception of great risk of smoking marijuana once a month, which is pretty low in all categories. And that's a problem only in, I'll speak about that in a minute. And the purple is perception of greater risk of essentially binge drinking once or twice a week. And that's too low as far as I'm concerned. And the yellow is the perception of great risk of smoking one or more packs of cigarettes per day. So prevention people have done a great job on tobacco. Not so much on marijuana, not so much on binge alcohol, but we're getting there. Oh, that's my. And this is DSM-4, DSM-5 drug use, substance use disorder. The first category is all illicit drug use disorder. These are not statistically significant, by the way, but we are higher than the United States for all drug use disorders, alcohol use disorders, and substance use disorder. This is non-medical use of pain relievers. I'm not going to go through my spiel again, but as you can see, We were significantly higher a couple of years ago, but now it's kind of the same for Vermont and the U.S. And this is again, we have this little break in the action here because I reformulated the question. This is non-medical use of pain relievers by the 3 age groups: 12 to 17, 18 to 25, and 26 plus. So, stop me if you want to ask about this.
There's another question?
Yes.
These are all data from the National Survey on Drug Abuse and Health.
Yeah, drug use and health. Right?
Any idea how many respondents there were from Vermont that this represents?
Yeah, about 700 to 1,000.
Divided over these 3 age groups?
Correct. But it's a very well done survey, and the sampling is statistical, epidemiologically accurate. So it does represent the population of Vermont. Okay, let's talk about the BRFSS, which is the Behavioral Risk Factor Survey system that gets done annually in Vermont, and this is a survey of 18 years and older. It tends to be, since Vermont tends to be a little older in their demographics, the median age, I think, of the BRFSS survey is in the late 40s, early 50s. So you'll see what that's significant about that in a minute. But it reflects again the National Survey on Drug Use and Health that we are, higher than the rest of the country in terms of alcohol use. And this is binge drinking. We're about the same, which is good news. And this is BRFSS marijuana use in the past 30 days in 2013, 2015, and 2016. And as you can see, it's gone up a bit. There was no question on marijuana use in 2014. There's another way to look at it. This is the percent increase. So let me just go back a second so you don't get freaked out here. This is age 65 and plus went from 1% to 4% in 2016, so that's why there's this gigantic increase from 300%. But these are also of some concern, obviously, that there is an increasing prevalence of marijuana use in Vermont. This probably is a good time to talk about this because, back in the good old days when I was growing up and marijuana was about 1 or 2% THC, there was a study that was published last year that looked at all the marijuana sales in the state of Washington, and the average THC, the average flower THC, which is the smokable kind, was about 21%. That's the average, which is incredible. You think about, we don't have any data on what this is going to do, especially to kids over time. And the average concentrate, which is what they extract the THC, is about 68%. So this is really concerning. We already have data on the adverse effects of marijuana over time, especially if you start early and you continue use. There's some very serious problems that can develop, not the least of which is psychosis, and that's been pretty firmly established. And I'll show you some of the work we did on that and where it's located in terms of the website. This is the latest data we have from the Youth Risk Behavior Survey. Vermont has one of the one of the better samplings because we sample. I think every school participates. Maybe 1 or 2 don't. So these data are really reliable and stable. So we're quite proud of this. And this is over the course of from 1999 to 2015. And as you can tell, it looks like we're doing a pretty good job in terms of prevention. So things are working out. So far, so good. Except for this marijuana is kind of stagnant at this point. This is past 30-day alcohol use. Again, the latest data we have is from 2015. And this is marijuana use. Again, we're waiting for the 2017 data to come out. Right now it's embargoed. And this is driving after using marijuana or alcohol. I find this interesting that there are more kids who are driving a car after using marijuana than alcohol. There's a lot of data out now that suggests that marijuana, but particularly marijuana and alcohol in combination, is very impairing for for driving skills, and this is not good news.
Yeah, and we don't know with this data if the kids or these young people had drank alcohol and smoked marijuana.
We do not.
Like, they answer it separately, so they could have been using both substances when they were driving.
That's correct. It's a tremendous concern, especially in a state like Vermont where it's so rural and people have to drive a long way to get to and from places.
You think that might be because, from my experience, when I was growing up, there was a lot of advertisement about, consuming alcohol and driving and the dangers of that, but there was nothing on, smoking pot and driving. Do you think could contribute to that?
Absolutely. I'm sure you're right about that, because I think and we'll get into this again, I think there's a perception in this, I think Robin talked about it, but anything but opioids, right? And, I don't care if my kid does marijuana, but as long as you don't do opioids, it's fine. And I think that attitude, that culture contributes to this, so I think you're spot on that.
What's the horizontal axis, 9, 10, 11, 12?
Grades, thank you, sorry.
Do people drive in 9th grade?
Well, yes, some of them do. If you flunk out a couple times, right? Now, this is prescription drug misuse among high school students. Again, this is good news. It's been decreasing since 2007. So we are making progress in that category. This is prescription drug misuse, 9th to 12th graders comparing 2013 and 2015 by county, and this is also good news. You can see they're going down quite a bit. Yeah. So yeah.
Good work.
Community effort.
And this is a correlation that was done in a study that was published last year that shows the relationship between substance use and reported grades. I mean, it's not totally not causal, but nonetheless, it's pretty suggestive that the lower grades that you report having, the more substance use you report having as well. So that's interesting. And this is Vermont data, essentially reflecting the same thing.
And I think it's important to just be aware that, again, these are asked separately, so we don't always know if there's polyuse happening, meaning like they could be drinking alcohol and smoking marijuana, or, so.
Yeah, we can look into that data, but that's not how we present it here. But
Yeah.
you're right, we can check that out. We don't know what the polydrug use is here for these data. Well, we always talk about these neuroanatomical effects of substance use and misuse on a developing brain. I can show you all these pretty pictures and show you what it looks like, but here's really what it's all about. Well, maybe it's not. There we go. Everybody read that? This kind of encapsulates what's going on in the adolescent brain and why we're concerned about substance use during this incredibly important developmental period. Here's I was talking about the health impact assessment of marijuana. We originally published it on January 1st of 2016, and the group reviewed 180 peer-reviewed articles published between 2009 and 2015. We did a literature update published last January, and remarkably, there was another 180 articles subsequent to these that we reviewed, and all these data are available on the Vermont Department of Health website. And then our commissioner is the chairperson of the Education and Prevention Subcommittee of the Governor's Marijuana Commission, whose recommendations he totally ignored, as you may remember. And anyway, there are reports that we put together about adverse effects of marijuana on a number of health and safety endpoints, and that's available here. So if you just Google Vermont Marijuana Commission, you'll get to the site, and then there's a link to the Education and Prevention Subcommittee, and then a link to this report, which was finalized in November. Okay, we have the Young Adult Survey, which is, as I mentioned, from Bob Flewelling and Amy Livingston from PIRE conduct this as part of the evaluation of some of our major demonstration grants. And the last one was done in 2016. There's one currently in the field, and it's done on social media. So here's the demographics of this group. Well, they're pretty evenly split in terms of males and females, which is great. This is 2014 and 2016. And here's an interesting thing to me, which is how did they take the survey? So in 2014, most of them were using a laptop or a desktop computer, and in 2016, they were overwhelmingly using their smartphones. So I find that just interesting. This is the alcohol data. Again, these are 18 to 25-year-olds for the most part. There hasn't been too much of a shift in the numbers here, so it's pretty stable.
And those are percentages?
That's correct.
You don't feel that the binge drinking in the last, for 1 to 3 days, is that not significant?
It is not significant, no. Right. But here's again, I hate to, this is of tremendous concern. Any use in the past 30 days, but here's the real kicker. 51.3% of those who reported any use in the past 30 days used it 20 or more days. Now keep in mind, we're talking about high frequency, high potency substance, right? We're not talking about THC that was back when, at least I was growing up. We don't have enough data, the long-term data, to indicate how this is going to impact a developing brain over a long period of time.
And for Windham County in 2014, that number was 60%. So 60% of the 18 to 25-year-olds who reported using marijuana in Windham County used it 20 or more days.
That's pretty scary. They might think this is unusual and is specific to Vermont, but this is from the National Survey on Drug Use and Health Data, and 20 or more days is reported by 43% of national data. The people who are, this is 12 and up. I'm sorry, 18 to 25. Again, the same age group, but it's a similar pattern, and it is of, I think, overlooked concern. I don't think there's enough people that are.
It's just like mind-boggling that like 40% to 60% of our 18 to 25-year-olds are pretty much high every day.
Every day, yeah.
Since that's
Yeah,
a lot.
it's terrifying to me. I don't know where this is going to go. This is the Young Adult Survey on Prescription Drugs. Again, not much has changed from 2014 to 2016, except the use of the overall use without a prescription has gone down, and some of these are significant differences. So that is good news, and we'll get the 2018 data sometime in the fall.
But the stimulants went up a little bit. Not much, but I noticed that the stimulants misuses, at least it hasn't gone down. It's gone up a little bit.
Yep. Yeah, well, this is what I was talking about before. Everyone talks about opioids. Everyone wants to know things about opioids because it's the front and center. It's what's funded. We get huge amounts of money from the feds to study opioids in every way possible, from prevention to treatment to intervention, which I'm not saying is a bad thing. I'm just saying that it kind of takes the spotlight off of other substance use and abuse in Vermont and across the country. How many people are misusing opioids in Vermont? Well, to be honest, we really don't know. We have some estimates between 10 and 18,000, which is a very wide confidence interval. In past year prescription drug misuse is about 14 to 22,000 people. In past year heroin use, again, these are very wide confidence intervals, and that's partially a function of the sample size, is 2,200 to 88,000 people. We are working at this point to try to refine these estimates using multiple data sources and indicators. It's hard to get a handle on it, but we also know that people who are using heroin also use other substances as well. So we're trying to figure out more precise answers to this question. But so far, this is the best we can do.
How about like fentanyl? Is this as now being used? Does that go into the heroin? Is that like getting kind of mixed in with the illicit opioid use? Like
They haven't actually separated those out in the national surveys.
And then, like other prescriptions, are there any studies being done on the benzodiazepines, like clonopins and
Well, we have,
amphetamines? Is that
yeah,
valued?
it's, oh, sure, there's prevalence, there's another problem with prescription drugs and benzodiazepines as well, so that's a real serious problem and can lead to morbidity and mortality as well. But again, it doesn't seem to be as important to the current cultural
Oh, okay.
focus, right?
Okay,
It's
right. It's
heroin,
just-
it's opioids,
okay.
so. And this is just all interesting because this is how many need treatment, and the questions are the survey is always how many people need but do not seek treatment, and you'll see it's about 95% of people who diagnose, and this from the National Survey on Drug Use and Health, do not seek treatment, and the main reason is because they didn't think they needed treatment. So this is a problem. I've always found this to be a problem because on the survey they just ask the symptoms, the criteria, and if you have the number that you need to make a diagnosis, that will put you in the I need treatment category, even though you may not think you do. So it's an interesting conundrum. This shows you what the over time how drug overdoses have surpassed everything in terms of causes of death. What we're trying to do is emulate HIV data. Remember, this is when the retroviruses and the treatments for HIV became widely available, and it dropped like a rock. So this is as the latest data we have, which is 2015. Again, these take a while to compile and put out there, but it is a lot of people make a big deal about there's more deaths from drug overdoses than there are car accidents. Well, part of that is the fact that cars are getting a lot safer. In fact, Volvo has announced that by 2020 they're going to have a death-proof car. So, yeah. I don't have any stock in Volvo, by the way. So, and again, it takes I put this slide up because it takes a while. This is cigarette smoking. Back from 1965, and they see it's a very slow decline. And this is among students. Again, the final analysis. It's great. We're getting where we want to go, although we're not there yet. But it's not something that goes from 42% down to 20% or 16% overnight. It takes years and years, and this is a huge success in public health. So we're not going to solve this problem in the next year or two, but we have to make steady progress on it. This is the percentage of deaths caused by drug overdoses in 15 to 44-year-olds in 2015. The yellow is not good news, and this is us up here in New Hampshire. Was in 2015 had a terrible opioid problem, as did Massachusetts and some of these other mid-Atlantic states. I just want to talk about methamphetamine because I noticed this a few years ago, that when we I think it was when there was a law to restrict Sudafed use. You have to, because there was this wave of methamphetamine use that was being predicted across the country. Well, what's interesting, this is 2015 data. As you can see, it pretty much, methamphetamine death rate kind of stops at the Mississippi with some minor exceptions, right? And opioids are mostly, the highest rates are in the east and the mid-Atlantic states. So this methamphetamines has never been a problem in Vermont or in the Northeast corridor. So whether it's going to it's come here or not, we'll wait to see what the newest data are. I just want this really incredibly interesting. Yeah.
I have a question about that. Now, if we looked back, to when meth first started becoming, popular, is that, in my mind, I believe that it was kind of like just like a wave coming from the West Coast over, to where it is now, the Mississippi River. Is that true?
Yeah, it started on the West Coast and as far as west as Hawaii and Alaska, but it never really made it past the Mississippi.
Okay, so it's been like that for
years.
For years.
Yeah.
Huh.
So
And I think at the conference, the workshop that Cassandra was referring to was mostly, I don't know if it was so much about use as the drug seizures and the high density, what does the I stand for? High impact density trafficking.
Oh, yeah,
drug
yeah.
Trafficking areas.
Yeah.
So there's certain states that are these HIDA states, and what they were saying is that they were seizing more cocaine, methamphetamine, and illegal stimulants than they were opioids now.
But probably that's, darn it, I have to learn how to work this thing. It's probably down in this area here. I mean, this is Walter White territory here, right?
Yeah.
And there's a lot of people out there who because of that program, believe that methamphetamine is a tremendously serious problem. I'm not saying it's not a problem, but it hasn't had an impact on the East Coast as of yet. Again, that's not to say that it may not. These are drug-related fatalities. This is the latest data we have, 2017. There was a total of 101. And I will tell you that up until November, we were going to go below 96. But then November and December, I think, had 12 drug deaths each month and really kicked up this total. These, by the way, are not independent, so you can have heroin and fentanyl and all of them combined, but the total number is what's important here. And we're glad that at least it wasn't this huge increase from 2015 to 2016. It was, I think, about a 5% increase from 2016 to 2017. So. And also, because of the low numbers, counties with statistically significantly higher rates of overdose vary from year to year. And interestingly, in 2017, there were no drug overdose deaths in Essex County. So probably it's a very low population area. So, but you'd think, just by chance alone, there'd be something happening up there. And you're all familiar with take-back days, where you get to put your drugs into a container. And I had the opportunity to look at some of the Burlington data. This is from 2012 to 2016. They had actual pharmacy students go through the drugs and see what they're getting. Well, they're getting a lot of acetaminophen. Aspirin and Advil, and not much of the scheduled drugs. So I think that something needs to be done about that. That there needs to be a more focus on not just drugs, but scheduled drugs that need to be returned. So this is the latest data we have, because they haven't been able to get the pharmacy students involved in the last couple of years, but I'm ever hopeful. So when they say they've collected 6,000 tons of drugs, it's a little misleading, I think. So what's important is getting these things off the streets.
And Scott brought flyers today, because we are having another Take-Back Day
April 28th.
Cool.
28th. And we are fortunate because of the work of the prevention coalitions that we have 5, 6, 7 now permanent drop boxes in Windham County. So anytime you have it locally, it's the police department, the sheriff's department, the health pharmacy, Brattleboro Memorial Hospital, Wynn Hall, fire department, and Dover, and two other places I'm not familiar.
Yeah, that's a real nightmare in terms of getting that stuff instituted, because there has to be multiple people involved. So that you may remember that there's been incidents in police departments where, I think it was mostly the one I remember is the one in Colchester, where the police officer was in charge of the evidence room and wound up, taking it. And so I know the person who was in charge of the take-back stuff, who just left us recently, was starting to put stuff together to make sure. It's just logistically, it's very difficult to get this going. So great news, and you guys are doing a great job. Another harm reduction program is the syringe exchange, and this, as you can see, is growing leaps and bounds, which is good news. This was initially done to try to impact the rates of HIV and hepatitis in the population, and it's been very successful. So this is another good program.
Do you have this data, the Hep C and HIV
Yeah, we have, I don't have it here, but we
Okay.
do have it as a specific program dedicated to that Department of Health. And,
Okay.
and it shows a tremendous impact of when these programs start.
That's awesome.
John,
We have two representatives today from
Oh, good.
Holly and they're both from the AIDS Project. Sue manages the syringe support program.
Yeah, well, this is one of the
they
best.
might want to add something.
Sure.
You want to say anything?
Sue, do you want to say anything?
It's been great.
Yes.
No,
It-
we've seen, we started, we reopened in October of 16, and we, as of now, have 102 members.
That's wonderful. Yeah.
Oh, 124,
Okay.
sorry.
That's really great.
Yeah.
So yeah, this is again a public health success. So congratulations on that. Okay, this is from the You Think We Got It Bad department. You think we're bad in Vermont. This is in Ohio. They had to bring in cold storage trailers to be used as morgues. 145 suspected overdose deaths in a single month. So this was last year. So Montgomery County, Ohio, where these data come from, has a population of 531,000. We have, 620, 625 here? So this is a little scary. In 1 week, they seized 66.2 pounds of drugs, most of which was heroin and fentanyl, street value of $2 million. 400 Narcan kits used so far. This was in April, so far in 2017 in that county. One inmate recently required 16 Narcan doses to be revived. And so far in 2017, there have been approximately 200 overdose deaths in, this is again Montgomery County. So not that, we're doing, this is just give you some idea of what it's like out there in the worst areas of the country. It's pretty bad.
But Robin, do you remember what that was? There was a teacher or something. We're talking about a teacher who had lost 80 students. Was that something?
I think it was Indiana. She lost 56 students that she was a teacher, had been a teacher at the high school. So these were students who had left, but she knew 56 of her previous students had died in this one little town in Indiana. And my family lives in Ohio, in Dayton, and it's amazing, like their attitude. Like I carry Narcan, and I was like, oh, you guys should all carry Narcan, and they're like, oh, like these are progressive people that do a lot of good work in the community, and their perception of the people that are using was frightening. So the work that we're doing here around stigma needs to happen, and that was mentioned a lot during the summit.
Well, it's a huge problem, no question about it. I mean, and we are doing a great job, with the hub and spoke system, with just our cultural attitude in general. I think the success of the syringe exchange program speaks to that as well. Now, I forgot to mention this last one, which is 10 OD overdose deaths on one day. So Montgomery County is not in a good position.
I'm just wondering, are there statistics of, like before Narcan was so readily available, and now that Narcan is pretty readily available of overdoses?
Yeah, I think that's an interesting question because I think the perception out there is that Narcan has had a huge impact on overdose deaths, and we don't see that in the data. It obviously has an impact on overdoses, but we haven't, for the last several years, opioid overdose deaths have increased across the country. So, and that's even, pre-Narcan and post-Narcan. So it's not a miracle drug. Obviously it will help people who've overdosed, but so far it hasn't had an impact on mortality. Okay, so this is the latest data on the top 10 states in the past year heroin use by age group. And as you can see, Vermont in all age groups is in the top 10, 12 plus, 12 to 17, 18 to 25, and 26 plus. I want to point out that these are very small numbers. So even though the bars are very large, you have to look at the axis to see that these are very small numbers that don't reflect, huge prevalence of use in any of the states. Right? So the highest in 12 to 17-year-olds is New Hampshire with 0.22% prevalence. So that's, again, this is a little misleading, but I just wanted to point out that Vermont is in the top 10 of the states in all age categories. This is the percent by age comparing the United States, the Northeast, New Hampshire, and Vermont. And this was that should be 18 to 25, not 18 to 15. New Hampshire's these numbers again are very low, but this sticks out. New Hampshire actually had a pretty good 2016. When you look at the mortality data, instead of going like that, it went kind of like this. So they've slowed their rate of heroin overdose deaths in New Hampshire, but it's still continuing to rise. This is a national map of heroin use in the past year among 12 or older by percentages. You can see it's pretty much concentrated here in the Northeast, in New England in particular, and then West Virginia and New Jersey and the other seaboard states, and Alaska as well for reasons I can't explain.
And it kind of follows that same pattern with the methamphetamines that the
Exactly.
higher states.
Yeah, I have no explanation for that. It's really puzzling that meth is on the west and heroin is on the east coast. Obviously, it's not exclusive, but it just observationally is quite interesting. And these are the number of people who are admitted to the state treatment for opioid use. Again, what we have is our prescription drugs falling off and heroin along with fentanyl increasing. And this is an estimate for last year. We don't have the hard data yet on that. These are the number of people who are receiving medical assisted treatment in the hubs and spokes, and the number of people in the waiting for services over time. As you can see, this is again a tremendous success. We put a lot of effort into this system, and the wait list is pretty much disappeared, which is, it's not quite treatment on demand, but it's getting close to it. So we're making a lot of progress. This is a nationally recognized model of the hub and spoke that is being replicated in a number of states. The latest one being California, which I don't know how they're going to do that with a population like that. And they don't have a central, in Vermont we don't have county health departments. We have a central health department for the most part, and then PCs in the outlying areas. But how they're going to implement this in California is going to be. They don't even know how many heroin. They don't have an estimate of how many people on opioids that they're even thinking about treating. So it'll be interesting to see how they implement that in California.
So what's the difference between the hub, the gray, and spoke, the blue? I feel like it's a dumb.
Oh, I'm sorry. No, that's fine. It's a great question. I always assume people know what the hub and spoke is, and the hubs are methadone treatment facilities, and it's mostly methadone, occasionally buprenorphine. The spokes are individual doctors' practices where buprenorphine only is administered.
Okay, all right.
So the more spokes we have, the better it is, obviously. And think about this. You can, if you go to the hub, you're going to go to a place with lots of other people that have your problem and trying to sell you drugs and do not nice things to you. If you go to your doctor and you sit in the waiting room with somebody next to you who's got a cold or has a broken arm, you're going to feel much more comfortable in that position, and that's what we're trying to get to. Although we'll never get to there 100%, but the situation with spokes is a much preferred outcome for this because people get wraparound medical care. So you don't just get your buprenorphine; you get your blood pressure checked, you get inoculations, you get everything. You're just a patient, but you're a patient with an opioid use disorder. That's the difference, and it's remarkable. So we're making progress in that category. Does that get it for you?
Yeah, no,
Okay.
I didn't know there was that component.
Yeah.
I always thought it was the clinics.
Yeah,
The hub at the retreat.
they're great for folks in early recovery, and the spokes aren't set up to handle, the doctors don't have enough time to, just making a wild generalization, but to deal with patients who have a higher level of need, like you are in, like where you're at in early recovery for the most part, and the hubs are set up to equip with clinicians there specifically to deal with, substance use disorder, and you have interaction with these folks on a daily basis or provide some structure. Yeah, they're the patients that are eligible to go switch to a spoke provider need to be in a farther along state of recovery, a little bit more stable.
That's
So
a
the
ver-
hope is they transition into
Yes.
the-
Yes.
That's an excellent
Okay.
point, which is,
Thank you.
a lot of them, most of them start off in hubs and then transition to spokes once they get stabilized.
One day we'll have that for methadone,
Mhm.
for the spoke.
Mhm.
I wish.
Not yet. Windsor County had the statistically higher rate of both overdose deaths and treatment, which is a little odd, but that's the way the data fall out. And these are the rate of accidental opioid overdose deaths per 100,000 people, and this is the estimated percentage of county residents who have received medication-assisted treatment during 2016. So these are pretty substantial rates. I mean, think about this, that something like 1.5% of Vermonters have had MAT, which is, to me, is remarkable. That's a lot of people. So anyway,
How many?
1.5%, 1.42. And this I just put in here because you guys are on the front lines, you know what you're doing, and a lot of people, I should say most people, don't understand the various statistical artifacts that we deal with and how we crunch numbers. So they have a lot of stories that they present, and this is just one of them. So this is actual data. Your lung cancer is a 25 times increased risk among smokers. Cardiovascular disease is substantial. COPD, 12 to 13 times increased risk among smokers, and there's all kinds of increased cancer risks among smokers. But some people have their own opinion, which is saying, this is something that was published in 7 Days last April, saying that smoking causes cancer is BS. My grandmother never smoked, nor my grandfather, and they both died from cancer. I don't smoke, and I have cancer for the third time. You have to register for the military at 18, and you're old enough and your brain is mature enough to go to war. But heaven forbid you're not smart enough to drink or smoke. A lot of old people smoke and drink, and a lot of them are in the State House. Seems to be a lot of hypocrites in there. No one forces you to drink or smoke, and no one has the right to tell you how to live your life, especially the fools in the State House. Just because their pea-sized brains think they know it all, and they have the right to tell us how to live. They can all go to hell, a bunch of liberals. So this is, unfortunately, this is how a lot of people think, and they look at epidemiological data and go, well, that's ridiculous because my grandmother and grandfather, never smoked and they both got cancer. So it's frustrating to say
Or
the
they
least.
smoked and they lived 200.
Oh, well, exactly, right. That's
I
right.
know somebody.
Yeah.
Yeah.
And this is my humor section. Why working for the West Virginia Tourist Bureau must be difficult. Their slogan is real, wild, and wonderful. This is, again, we went through this before, but as you can see, even West Virginia is not immune to methamphetamine. This is 35 years of American deaths, and we got West Virginia right in the middle. They're just not doing too well. And this is that was mental health and mental substance abuse. This is cancer, lung and other cancers. Again, West Virginia is one of the statistically higher rates. Anybody know what the state bird of West Virginia would be?
Vulture.
What?
No, that's my joke.
Oh my God. You had me.
Canary in the coal mine, remember? So. All right, so you have to be careful with this. I have to show you. This is a pretty graphic picture of what you look like when you're passed out.
The horror.
It's my cat Finn. And those are my other two cats, Little Bear and Chloe. So that's it. Any more questions? It's been a real pleasure being here for you guys. Yes.
Maybe a comment, the lack of impact from the wide deployment of naloxone, Narcan, may be accounted for by the lack of engagement of people revived into some sort of a treatment process.
Absolutely.
There's more and more of an effort to create warm handoffs so people get into some sort of treatment. Having them motivated for treatment, though, is another matter.
Absolutely.
Often they wake up and they're motivated to override the Narcan.
Yeah, they're also wake up angry.
Yes.
Yeah, that's a very good point, and I think hopefully it'll have some impact in the future, but we just don't. It just is not working at this point. I mean, it's reviving people, but it's not having an impact on mortality.
There was a speaker at the summit who talked about how it should be considered malpractice to release somebody from the emergency room who came in an overdose, because you're sending them right back out to the disease. I mean, it would be like releasing a patient that you know has a heart condition that if they walk outside they will drop dead.
And they won't release them.
Yeah.
Yeah.
And they are, right, so what we have to get more diligent about doing, and there were a lot of programs that were presented about the soft handoff from emergency rooms into, and we do a little bit of that here, you know, we do have, we're fortunate to have a law, at least in Brattleboro, the chief is really looking at how to approach people, that are struggling with substance abuse disorder, helping to get them into treatment and not just arresting them or, you know, scooting them off the sidewalk or whatever. There's more of an effort with social workers to reach out. And I also just want to put in a plug, you mentioned the brain development piece, and, you know, it's true. It's not blaming them for making stupid decisions. It's about where their brain is. And with boys in particular, the testosterone that's racing through their body goes straight to the amygdala, which is the risk-taking part of the brain. And for girls, the progesterone, estrogen is creating the up and down, I hate you, I love you, I hate you, I love you, theory, you know. And so when we add substances to that mix, you know, we're setting the brain way so that when opioids come in later in life, and that is the trajectory, is it's later.
That's correct.
That there's a problem. And so the event that we're having on the 23rd here at the library at 5:30 is going to talk about that brain development piece a little bit more in depth and why delaying the onset is really still doing opioid prevention.
Yeah. And you should be, again, I hate to beat a dead horse here, but you should really be concerned about this high frequency, high potency marijuana it's in the marketplace right now. And the other thing is, you mentioned the Juul, the vaping thing, which the company says, oh, we don't want kids to use our product, even though they're, some of the flavors are like fruit and mixed berry and things like that. This is going to be a problem in the future as well, because I've never had one. Every time I see people on the street vaping, there's this gigantic cloud that comes out. But these apparently don't.
Well, it does. You can get it so it doesn't plume, and it doesn't really have an odor.
Right.
And they look like USB port cartridges. And we just bought one on eBay. There was 6,000 cases you could buy the pods from, and it's about. You can get different sizes. I think when we got this was like this size, and about 200 inhales is a pack of cigarettes, and this is what kids are using. So.
And they can do it surreptitiously, right? I mean.
Definitely, and parents just aren't even aware of it. And we just used a credit card and bought it through and had it
no age verification.
mailed to us. So it's just it's something that parents and school staff are just trying to get on it. But we talk about it's like the potency of the marijuana when you have something that's a pack of cigarettes. What's a cigarette gonna like the level of nicotine of a pack of cigarettes? The rush from that and then the withdrawal from that is gonna be that extreme. So it's just something that we're really concerned about because these kids are really using it to get high.
Yeah, and I think,
and it's not. It's not to be. I mean, it's cool too. It has this gadgety kind of thing. It was made by two 30-year-old men. Techie kind of guys, and so it's like got this kind of cool gadgety kind of feel too. So it's something we're really having to keep an eye on and really concerned about, and the FDA is not even regulating it, hence it being on eBay.
There's also I think a widespread myth among many people that nicotine is not addictive. It's the other stuff in cigarettes that was addictive, which is completely false, right? But that's partially why kids are getting into this, because they say, well, it's nicotine. I'm not gonna get addicted. But I don't know where this is going to go, but it's not going to be good.
And the other thing that users just realizing is that we found out people who continue to smoke cigarettes while they're on treatment for other substances are more apt to relapse, especially around stimulants. There's actually the same neural pathways for cocaine as to nicotine. So a lot of times somebody who's in withdrawal in recovery for stimulants, especially they did a specific study around cocaine. if they kept smoking, they had like a significant increase of relapse, and so that also concerns me if we have kids that are misusing stimulants and
Yeah.
nicotine, how that will just kind of end up being this, again, poly or poly just means more than one drug use of that kind of, yeah.
Yeah.
So,
No,
I think it's good just to let people know there's a lot more out there than the opioids, and it's also can lead to the trajectory to these more, what people are more concerned about.
Right. And I just want to mention that, we put all these strict rules for opioid prescriptions in place last July, and there's been a lot of publicity around prescription drugs. And as you saw, we are going down. And part of the problem is, it's like a whack-a-mole. We've got a handle on the prescription drugs, and now heroin is going up because people can't get their prescription drugs as easily. So this is such a complex problem. And, stigma goes into it. Poverty goes into it. It's really, you have to look at it from a number of perspectives in order to even approach solving that problem. So it's not going to be, again, as I said, it's not going to be next year. It's going to be a while before these opioid overdose death rates go down.
On a positive, so just to end on that, they did say at that training that they are coming up. I spoke with somebody who's coming up with a medication to help to reduce the withdrawal, if not remove the withdrawal symptoms of opioids, which is pretty significant. So that a lot of people don't quit using the opioids because it's such a horrendous withdrawals process, and so they're actually coming up with drugs to actually keep the body from having to go through that. So hopefully that will help people in the earlier time
Yeah.
of the recovery. So
That's mostly the reason that people continue to use opioids is because they want to avoid the withdrawals.
Mhm.
So if you can get around that,
yeah.
you're going to
I
get
was just
people.
like, I'm really feeling good that that's something
Yeah.
that's going to become available. So
Yeah, that's good
I
news.
mean, it's not really specific to that, but thanks.
Yeah.
Thank you, John.
Anything else? Well, thanks, guys. Appreciate it.
Thank you.